Thank you very much for that kind introduction, and to the organisers for inviting me to come and speak at this excellent meeting. So the focus of my talk is going to be building on the previous speakers' talks. You've made the decision that you want to prolong CPR, and I'm going to be focusing on the how and the where do you go about doing that. So firstly, addressing conflicts of interest. I've received funding from the UK government to evaluate the Lucas mechanical chest compression device, but I don't have any commercial conflicts of interest. I do have a number of volunteer roles, and I'm also an editor for the journal Resuscitation. But I don't think that those are going to have a big impact upon what I present to you here. So I'm really going to aim to cover these four things in this talk. I'm going to look at the importance of high-quality CPR, how to maintain high-quality CPR during prolonged resuscitation, and then have a look at some of the practicalities of switching to mechanical CPR, when and how, which device to use, how to manage complications, and then whether there are any specific complications that you should be looking out for. And then finally, I'll just touch on monitoring that you might like to consider during ongoing resuscitation with the mechanical chest compression device. The last 5 years has really helped articulate the importance of high-quality CPR with a number of studies demonstrating that what's been taught for a number of years to push hard and to push fast and to not interrupt your CPR is increasingly important. So this study on the left there was a study from the Resuscitation Outcome Consortium showing the relationship between chest compression depth and survival to hospital discharge, with deeper compressions being associated with better outcomes. Over on the right-hand side of the slide are a meta-analysis of studies comparing shallower and deeper compressions and showing a consistent survival benefit when you're compressing the chest more deeply. If you look at chest compression rate, again, another study from the Resuscitation Outcome Consortium, 6,000 patients. On the right-hand side, you can see a sweet spot. Optimal survival is seen when chest compressions are delivered between 100 and 120 a minute. And over on the left-hand side is the relationship between chest compression rate and depth, which shows that the harder or the more rapidly that you compress, the more difficult it is to maintain compressions of an adequate depth. Finally, keep going and avoid interruptions in CPR, particularly around the time of delivering a shock. Interruptions in CPR lead to a reduction in coronary perfusion pressure and reduce your chances of achieving return of spontaneous circulation. Now, in the focus of delivering prolonged CPR, of course, it's actually physically very demanding. It's very difficult to maintain high-quality manual CPR for a protracted period of time. On the left-hand side of the slide, you can see that the quality of resuscitation and chest compression depth falling minute by minute as people are performing standard manual CPR. Over on the right-hand side, you see evidence that shows that you can mitigate some of that decline by switching your resuscitation operator every 2 minutes. But even with that, which are the grey-coloured bars, you're seeing a significant decline in the quality of CPR, and actually getting people to switch at the point that they start to feel tired is potentially a more optimal strategy. But take what you may, it's a challenge to deliver high-quality CPR for the type of durations that we were hearing about in the previous study. Add on top of that some of the logistical considerations. It's near impossible to do manual CPR whilst extricating a patient down a flight of stairs. And mechanical chest compression devices potentially play an increasing role in that situation. And of course, transporting a patient into hospital, significant reduction in the quality of CPR, as it's again physically very demanding to deliver high quality CPR in the back of a moving vehicle travelling at speed. And if you add on top of that some of the challenges and risks that you place on unrestrained ambulance staff through travelling at high speed, you can see some of the potential benefits of a mechanical chest compression device. I'm not going to dwell particularly, as I was conscious that the previous talk was going to focus on what types of patients we should be doing prolonged CPR. But I think my take-home message is very similar, is that for most patients, start with the standard resuscitation algorithm, think about the prognostic factors that are going to lead to you thinking, I need to carry on for that little bit longer, or I potentially need to transport this patient into hospital. Now, there's a whole number of different mechanical chest compression devices, and here are just some shown on the slide here, but I'm particularly going to focus on the two devices here, the Lucas mechanical chest compression device and the Autopulse. And I do that specifically and intentionally because those are the two devices that have had the most research and the most understanding about the effectiveness or otherwise of those devices. So just looking at the 4 large multi-center trials that have been done, the first 2 trials, the Aspire trial was done over a decade ago. It was a multi-center study that enrolled 1,000 patients, and it was actually terminated early by the Data Monitoring Committee because of worse neurological outcomes in the group assigned to receive mechanical CPR. The CIRC trial built on that. It was also a multi-center trial, this time in the US and Europe, and it individually randomized patients to high-quality manual CPR or standard CPR, and that both of those were industry-focused studies. The LINK study was European, particularly a Swedish study, looking at the Lucas device in out-of-hospital cardiac arrest, and then our own study, the paramedic study, that was a clinical effectiveness study and independently funded. It almost hurts me here to summarise all of the work that I know that I and others have done by summarising really the enrolment of 12,000 patients on 2 slides. But this is the forest plot and the meta-analysis showing the impact of the routine deployment of mechanical chest compression devices on survival to discharge, and neither the Lucas nor the Autopulse device associated with improved outcomes. Similarly, for favourable neurological outcome, no improvement with the routine deployment of mechanical chest compression devices. And this informed the International Liaison Committee for Resuscitation recommendations on these devices, and this is to recommend against their routine use to replace manual CPR. But the guidelines or the recommendations do highlight, as I've started to allude to, that there are specific situations where you have no option. It's not possible to continue with manual CPR, and in that situation, mechanical CPR becomes increasingly important. So again, given the previous talk, I'm not going to focus on the debate of the types of patients, but move straight into the practicalities. And in thinking about the practicalities, I guess I just put this slide up to, again, emphasize the importance of starting your resuscitation using conventional methods. So start your resuscitation attempt using manual chest compressions and avoid delays or interruptions, particularly in those patients with shockable rhythms. And my rule of thumb is before transitioning to mechanical chest compression devices, make sure that you've delivered at least 3 shocks so that you've done around about 6 to 10 minutes worth of high quality advanced life support. And that's informed in both the Aspire trial and also our paramedic trial that there seemed to be a signal suggesting that there may be harm with the early deployment, particularly in patients with shockable rhythms. Why is that? I think there may be a number of reasons for that. It's possible that the interruptions in CPR may be harmful. It may be that the deployment of the device early leads to a delay in the delivery of the first shock. Although these data may also supply some explanation, because with mechanical CPR, people often keep the device running while they deliver shocks. And certainly for the Autopulse device, there is an interaction, as you can see, that if you deliver the shock at the wrong time, it's associated with less success. So let's look briefly at the practicalities of how to deploy a device. In essence, start with manual CPR, deploy the backboard, and then resume standard CPR. And I'll just
With its unique stabilizing board, the Autopulse provides continuous, high-quality CPR. Easy to use and battery operated.
Deploy the board.
It's extremely mobile
CPR
and versatile,
and then deploy the front.
can be applied to patients in seconds.
hopefully what you've seen there, that even in the best well-trained hands, that there's still interruptions in CPR, and so that must be your focus when you're deploying a mechanical chest compression device. And quality improvement studies, this study from Marcus Ong in Singapore showed that if you actually train and drill the crew, if you get them to practice on a mannequin, you time them, you film them in operation, and you allocate tasks, that you can have a significant impact on the no-flow ratio and the time taken to deploy the device. Similarly, in this quality improvement initiative in the States, they focused in by delivering lectures, testing staff, doing mock CPR drills, and then reviewing downloads and providing feedback to people, focusing in minimizing interruptions in chest compression. So I think if you're going to be using mechanical devices, then you need to make sure that the people are trained and equipped to use those competently. Of course, technology runs the risk of malfunctioning, and both devices, or all of the devices, will have an error rate or a problem, and some of that may relate to maintenance, other of that may relate to battery duration and what have you. But there are a number of reasons that the device may fail, and the key if the device fails is to recognize it instantly and to immediately resume manual chest compression. So with the Lucas device, it's very easy to just unclip the top and to start manual chest compressions. And with the AutoPulse device, even with the band on, you can deliver the chest compressions through the band. So the key message for managing device failure is don't focus on the device, focus on the patient, maintain high quality CPR. In terms of monitoring during mechanical chest compression, I don't think that there's anything particularly special that you should monitor beyond what you would be monitoring with manual CPR. And I think of those, capnography is helpful, particularly for confirming tube placement and in the logistics of lifting a patient up, making sure that you haven't displaced the tracheal tube, but also looking at the quality of CPR. And you may find some evidence, if you see a marked increase in end-tidal CO2, that there's been return of spontaneous circulation. There are some animal data that suggests that basing your resuscitation on the physiological response to resuscitation, so looking at aortic diastolic pressure and end-tidal CO2 in animals rather than focusing on chest compression depth, leads to improved outcomes. And in this large study from the US, from the Get With The Guidelines group, there was a small incremental improvement in return of spontaneous circulation, where physiological endpoints were used to guide the resuscitation attempt, but those weren't sustained to discharge or favourable neurological outcome. So I think this concept of monitoring the physiological response to resuscitation is something that we're going to see more and more moving forward. And again, we heard with the previous speaker starting to talk about ways of monitoring brain function, so that we're not just looking at systemic circulation. Moving to the last couple of minutes of the talk, I've got two slides on injuries associated with mechanical CPR. And I think I'd highlight first and foremost that these studies generally focus on patients that have died after an unsuccessful resuscitation attempt. And I put to you that that's not as important as the patients that survive. And so injury patterns in patients that don't survive is less important than the overall impact of your treatment, because of course the patients that do survive, that have the good outcome, aren't the ones that are caught in these post-mortem studies. But as you can see here, the patterns for the Lucas device fairly similar. A greater proportion in the mechanical CPR having rib fractures, and then similar numbers facing internal organ damage. Looking very briefly at the AutoPulse device, again, this was a post-mortem study and a post-mortem CT study, showing a significant increase in the proportion of posterior rib fractures associated with the load distributing band, and also some increase in the intestinal injuries that patients are suffering. But again, do remember that these are patients that have died, and it doesn't represent the overall sample of patients that have been exposed to mechanical CPR. Perhaps the best study that we've got in this regard is a study from Rudy Costa that again is just published in abstract format at the moment. And this was actually a randomized controlled trial looking at injuries that occur in patients randomized to either manual or mechanical CPR upon arrival at the emergency department. And it was designed as a non-inferiority trial, and they were able to exclude any evidence of harm in the Lucas arm. But the study wasn't able to exclude any difference in those receiving mechanical CPR. There we go. Caution against the routine use of mechanical CPR, but it is useful where you're focusing on prolonged CPR. When deploying the device, minimize interruptions in chest compressions and be alert to CPR-related injuries in both prolonged and mechanical CPR. Thank you for your patience.